Hi, everyone. We're excited to start this Imaging Core steering session. This is a time of transition for our core, and so I will be stepping down as chair, and that gives a good transition to welcome up Dr. Annie Cohen, who will be taking over the role as chair for the upcoming year. And she's going to provide some imaging updates from our steering committee, and then we'll be back with updates from other groups.
Oh. I'm too short to see my slides over the podium. Good morning, everyone. So we're just going to do a quick update about the Imaging Core Steering Committee and the initiatives that we've been working on, and this will be very quick. As Emily already mentioned, she is rotating off as chair after doing a fabulous job over the past year. And she will serve as past chair for the upcoming year. I am rotating on to chair, and Shannon Rishiker from Indiana will be coming on as co-chair. We're also welcoming new members, Mark Lowe from Cleveland Clinic, and Renaud Lejoie from UCSF. And we also will be having another election for a third member that will be coming soon after this meeting. And we are thanking Dr. Sterling Johnson and Dr. Beth Mormino, who are both rotating off after 4 years on the committee and really leading the committee into what it was today. When we just want to thank them. There's some weird animations happening. We also wanted to include Sam Lockhart, who is coming to us, or is leaving Wake Forest and also rotating off the committee. So this year, we've been meeting monthly with NIA and NAC. We're responsible for the agenda for the Spring Imaging Core session. We provide feedback to NAC, NIA, and to core leaders trying to improve interactions among centers and the ADRC program as a whole. We collaborate with SCAN, NAC, and Clarity on new imaging initiatives and sort of advice of how things can be improved from an imaging core perspective. And then we also set 1 to 3 annual goals that we try to work through as a committee during the year. Historically, one of the things that we've been heavily involved in is supporting SCAN startup and integration. And for those of you who attended the meeting last year, you'll remember that Cerise presented a great presentation about the barriers that many sites are experiencing and the opportunities for more imaging in Alzheimer's centers. So that was also one of our goals. Over the past year, we've been working again to coordinate with SCAN and NAC on both intramural and extramural data sharing. So working through those data releases that you all have been receiving and working with SCAN and NAC on the imaging uploads. We've been collaborating with other steering committees. In particular, at last year's meeting, we had a joint session with the ORCOR, and we're hoping from that will come a centralized resources related to imaging for recruitment and education, and also promoting the use of ADRC imaging data that Bill Jagist is going to talk to you a little bit about when he talks about the SCAN initiative. So for this year, our upcoming goals are to support Clarity in its startup and integration, and Sterling will be talking about a little bit about that. Coordinating with SCAN and NAC again on promoting use of that data and data sharing. We've been in discussions to collaborate with other steering committees, including potentially a white paper on imaging and biomarkers in the new era of treatments, and we feel like that's a real opportunity to collaborate across the core committees, and promoting the ADRC neuroimaging core findings at AAIC. We're hoping to put together a curated list of presentations that come from ADRC neuroimaging cores that all of our centers can go to and find those in a readily available place. And then finally, if you have an idea, reach out to us. We're very open to hearing about opportunities and barriers that you're experiencing, and we'll be huddling at the reception, so if you want to come find us to suggest any of these things that you don't necessarily want to shout from the rooftops here, we're happy to hear about that. So now I'm going to pass it back over to Emily, and she's going to introduce the rest of the session.
All right, so next I'd like to welcome to the stage Dr. Bill Jagist from the University of California, Berkeley, and he's going to give us an update on the SCAN initiative. As Annie mentioned, we spent a lot of time connecting with SCAN, and I think we're hitting a really important transition point where we're talking less just about data collection and also now transitioning to data sharing and data use. So, Bill?
Thanks, excuse me. Thanks, Emily. So basically what I wanted to do today is, I realized as I was getting ready for this talk that I didn't really go into a lot of the nitty-gritty about how to upload your data, how to download data, what your dashboards are showing. I think you'll get a lot of that in the next 2 days. Excuse me, but I think what I really wanted to do is show you how exciting things are getting, and we're actually getting data, and it's looking like a lot of fun. So these are my disclosures. I want to actually start with giving you an overview of where the MRI data are. That's actually a bit more complicated than the PET data. Cliff and I spend a lot of time working on these things, and he's constantly reminding me how much more complicated MR data is than PET data, and he's absolutely right. So you can see here that on the level of the exam, which is basically the whole session that a participant will have, there have been about 5,000 scans submitted, and about 3,000 have passed QC. So that's at the level of the whole exam. The exam contains multiple sequences, obviously. And so when you break it down by series, which are the sequences, there's 22,000 sequences. So that's quite a lot. And they've had to sort through these. And in the process, what they find is that about 5,000 of these are not relevant. They're things like scouts and so forth. That about another 5,000 have errors, like they've been defaced by the sites, or there's missing slices, or the parameters are wrong. Then they go through this defacing process, and they're checked for visual QC, and another 800 or so of those have failed. And then there's a bunch that you can see on the upper right that aren't released because they have medical findings or other issues. And when it all comes down to it, you can see at the very bottom the numbers that have been released, still quite substantial. So close to 3,000 T1 sequences and flares, and progressively smaller examples of other sequences. So the T1s and the flares are the core exam in SCAN, and those have to be there. So we're doing, I think, pretty well. We're not up to date on analysis, as you'll see, and that's because a lot of the T1s and flares have actually been released in the last month because we had some snafus, so we haven't caught up fully yet in the analyses. When I say we, that's the work that's done at UC Davis by Charlie, actually, DeCarli. So this is a nice overview of what we have in SCAN, and I'm going to be showing you a bunch of slides with data. And if you pay attention, you'll notice the numbers are different. I'll try to explain why they're different, because some of them contain MRI data, some of them contain FDG data, and some of them don't contain FDG data. So the numbers are a little hard to track, but this is kind of the starting number that gives you an idea of how much data we have. 3,600 MRI and PET scans in about 2,200 participants, and the Venn diagram shows you the overlap. Now, one thing to remember about SCAN is almost all of these scans were contributed by ADRCs sort of voluntarily. There was a supplement, as you will remember, a few years ago that paid for the acquisition of these scans, but many of these scans were contributed based on funding from R01s and other ongoing research at the centers. So the standardization in terms of everyone having an amyloid PET and a tau PET and an MRI just wasn't there. We took what we got, and you can see how this ended up overlapping, despite the fact that there wasn't standardized. There's still quite a lot of overlap between the different tracers and modalities. When you start to break this down by MRI versus PET, you can see that a lot of these scans don't have associated MRIs. This is here the total number of scans without the MRIs, but adding in longitudinal scans. And there are a substantial number of longitudinal scans. But overall, across all the tracers, you can see that about half of the PET scans don't have MRIs. So we've developed analysis pipelines that don't require an MRI. We've tested them, and they work quite well in terms of being very highly correlated with an MRI-based scan. You'll see the PI 2620 there. There are a couple of hundred scans which we haven't analyzed yet because they don't conform that well to the atlases, and we're still working on that. So now I just want to tell you about some of the data. These are the subjects that I'm going to show you. These are about, again, the number's getting a little smaller. We've thrown out the subjects who only have MRI. We've thrown out the subjects who only have FDG. There are groups that are of non-Alzheimer's MCIs. We've thrown out the longitudinal scans. So what you're seeing here is unique subjects with one scan or more, but we're only looking at the baseline. And you can see that, you know, there's quite a lot. Most of them are normal. The age range, the sex, the underrepresented group membership is actually, it's not great, but it's not, it could be better, but you can see what it is. And the percent amyloid positive sort of follows what we think it ought to be given the diagnoses. So now let me just show you some data, and this is sort of what I think is exciting. So this is, now remember, we've got 4 tracers. We've got PIB, florbetapir, florbetaben, and NAV, and these are the diagnoses, split by diagnoses. So you can see the means following pretty much what we think. We've got a tentative threshold where we say below 10 you're negative, above 20 you're positive, and you know that for now we're using that. It seems to work, but you know, we're going to try to refine this. And here's the actual tracers. So I think what I get when I look at this graph is how much the distribution of each tracer, when you put it in the centiloid scale, maps well to the other tracers. It's not 100% perfect, but it's pretty good. The range is good. The shape of the curve, if you imagine the histogram on the y-axis, the shape of the distribution is pretty much what we expect. We don't have a lot of non-Alzheimer dementias, but you know, that's not as interesting, I guess. So anyway, for these 4 tracers, it's looking great. Here's the tau data. We have a little less tau data, and the 2 tracers that we have are fluortaucipir and MK6240. And again, what you can see here is that for the entorhinal cortex and for the medial metatemporal ROI, the data look pretty much like what we would expect. And again, not much to say about this except that it's conforming to other large data sets that have been published. This is a very interesting slide to me because this is really one of the tests of whether the relationships we've seen in biomarkers is holding out in the scan data. On the x-axis is the amyloid and centiloids. On the y-axis is entorhinal cortex or metatemporal SUVR. If you can't read it, in the top row, the R is 0.6 for fluortaucipir and 0.66 for fluortaucipir and 0.67 for MK. That's probably a lucky coincidence, but it's remarkable that it's so similar. It's also very similar for the metatemporal ROI as well. And then this is the hippocampal volumes on the left by diagnosis. And again, these MRI data are very much following what has been published in Alzheimer's disease. And, you know, nothing to jump up and down about, but reassuring. A lot of these data to us were sanity checks and done for the purpose of assuring ourselves that all of our processing pipelines are giving us what we think we should get. And then on the right are graphs showing the relationship between tau and hippocampal volume. And again, for fluortaucipir and MK, the effect sizes are very, very similar. Just going to my last data slide is some work that's been done as part of SCAN by Beth Mormino's lab at Stanford. And Beth received funding to go back and track down scans that were performed before SCAN started. All the data that I've just shown you are prospectively acquired to our harmonized acquisition protocols. But these were collected before SCAN started, so they had to go out and get these data. It was pretty complicated to track down what fit and what didn't fit. And you can see there's another 1,300 amyloid scans and another 200 tau scans. And again, here in terms of the amyloid data, it looks very much like what we'd expect. These data were processed in the same pipelines as all the other data, and this will be merged with all the other scan data that I've shown you. Again, these are all ADRC patients, so this data will also be available Yeah. So let me just end with some requests, particularly for the MRI core, to try to deal with some of the problems that we've had with a lot of failed scans in the pipeline, especially in the series that have been uploaded. And so these are things to just try to remember when your sites are thinking about uploading MR data, to use the scanners that have been certified for the ADNI-4 protocol, and Brett Borowski at Mayo is the guy who can help you with that. The study began January 1st, 2021, so scans before that are not compliant with the scan protocol. Please don't deface the series at your own center. That messes things up a lot, and I know that there is software out there to do that, but if Mayo gets a defaced scan, they can't run a lot of their processes on it. And the same thing goes for anonymizing the DICOM files. That gets done at Loney. You don't have to do it. And again, if the DICOM files are stripped, a lot of the information in the headers is gone. And finally, if you upload the same exam more than once, it adds a lot of unnecessary work. And obviously, a wrong patient ID is also a problem. So that's it. If I have time, I'll be glad to answer questions. Yeah.
We have people in the virtual audience that need to hear.
So, Bill, you've done all that wonderful work with the centiloid scale across all those very different tracers. Is there some algorithm that you can share with the sites to help them to normalize, even if they don't submit to scan, but to just make use of for their own sites, maybe with legacy data, et cetera? Yeah, so, well, first of all the centiloid numerical data is available to you, that just for these studies. I don't know if we've done it yet, but we have, I'm sorry, actually, it's on the ADNI site, but we'll publish it somewhere else if we need to. All of the equations for converting from SUVRS to centiloid are public, they're out there. It's a matter of making sure that you know where they are. I would say one thing, though, with a great degree of caution, and that is that centiloid equations are made for the processing pipeline you use. So if you have your own way of processing the data in your lab, you have to derive the equation using that processing method. Yeah, is that Jim? Yeah.
Come on, yeah, there we go. As you know, I'm not a big fan of defacing. I don't think it's a HIPAA violation, and I don't think creating it to be a HIPAA violation is a good thing. I think we're seeing the impacts. If Mayo says, we can't run our processes if you've defaced it, I don't deface ours, then what are we going to do after they deface all the ones that we're going to share? That, I just think it's corrupting the raw data, and it's going to be a problem going forward.
Well, so I sort of have two responses to that, Jim. I think that defacing has indeed imposed an extremely complicated processing step into the data flow of our images. And whether it's worth it or not, it's not my decision, I think, but I do think it might be worth discussing in more detail. The only thing I would say is that as far as the defacing that's being done now, in terms of most of the software that's been tested, it has no impact. It has no impact on things like Atlas matching, free surfer segmentation, or parcellation, or any of those things. So I don't quite agree with you on that, on the second point about that.
Incredible collection of data. It's just, I can't believe so much has happened so fast. It's great. I just had a question about the failed scans. Do we know what the criteria might be for failed scans in terms of, do you think it's all technical? Is there any possibility that there are participant variables, diversity variables that could be responsible for failed scans, or could be more prominent?
So I don't think we've gotten to the level, I'm now speaking for the Mayo Clinic group, well, actually there have been a substantial number of failed PET scans too, but not quite as many. So I don't think we've gotten to the level where we could say that these are related to any participant characteristics. They're almost entirely technical. Now, whether there are different groups that have, the big thing is head motion or excessive motion, and whether that's related to participant characteristics in some way, it certainly could be. So I don't know the answer to that. But by and large, the vast majority of them have been very, very basic things like, the wrong sequence, the wrong parameters for the sequence. What was labeled as a T1 was actually a scout. Very, very basic kinds of things. Is that good? Thank you.
All right, thanks, Bill. Okay, we're going to transition now to Clarity updates, and I'd like to welcome Sterling Johnson, as he's making his way. So the Imaging Core Steering Committee is one of the newer kids on the block, and we were formed in 2020. And I'd really like to give a huge shout out to both Sterling Johnson from Wisconsin and Beth Mormino, who were original members of that steering committee. And Clarity is the direct result of those Imaging Core Steering Committee meetings, many meetings with NIA, many surveys to you, the ADRC. So really a huge thank you to the community. This is a reflection of actually meetings that started even before the steering committee was formed back in London in 2017, I think. So here, this is a really exciting that now we're talking about data being available through SCAN and data collection just starting through Clarity. So lots of good transitions here. Welcome.
Thank you, Emily, and thank you all for supporting this project so far. Clarity is it truly is a consortium of the centers, and it wouldn't have been possible without lots of great ideas to put together into this consortium and the willing collaboration from all of you. We are, I don't have any data slides to show you because we haven't collected any data yet, but we are very close to being at that point. We have, looks like my slides are on a timer. We have a team of PIs. We've got many people collaborating on this project with the overall vision of creating comprehensive biological diagnoses and staging so that we can treat these diseases as best that we can. So our goal with Clarity is to create individual etiologic profiles from imaging and plasma. We'll be collecting ATN imaging using the SCAN protocol that you just heard about from Bill. We'll be doing 2,000 ADRC participants. In the most recent survey that we did with you, you said you could actually enroll 3,000 participants in Clarity. We only need 2,000. That means there's lots of headroom for the other things that you want to do with your P30. We want diverse representation for generalizable science, and Dr. Okonkwo and Dr. Rivera-Mint are providing leadership in that, as well as the Core Steering Committee. Thank you all. 2 time points, and focusing on the strengths of the ADRC, which is all the heterogeneity that we have within the center's program. This is where we are here in what's now close to the middle of 2024. In Q2 and Q3 and Q4, we'll be developing subawards and finalizing those subawards with each of our sites, each of you, and getting sites qualified and hopefully running studies very soon. We anticipate the first visit of the first patient could still be this month, later this month. The overall goal is to, in terms of recruitment at least, is to finish this up by the end of 2026 in terms of recruiting 2,000 people, and then follow-up imaging in 2029, by the end of 29. Here's where we are in terms of some other aspects of this. IRB approval is in place. FDA IND permission to proceed is in place for the 3 experimental tracers we're using. The site subaward contracting is underway, as I said, and site training will happen a little bit after that. And so please don't enroll anybody or do a Clarity procedure until all that happens. While we're doing that part of it, NAC is also building the databases and the the tools to upload all the images so that we have those available for us. We'll hear a little bit about the inclusion core later today at the breakout session over lunch. We'll also hear about our disclosure plans from Annalise and Lindsay and Nate also over the breakout session. And over the next couple of slides, I just want to mention some of the other things that are happening. We really are, the foundation of the MR protocol is the scan tier 1 set of sequences, the scan T1 weighted volume and the scan flare. To that, we are adding some optional is, I'll stress that word, neurodegeneration focused advanced imaging. The first sequence is a multi-echo gradient echo sequence that will give us QSM and susceptibility weighted imaging in one sequence. And that's aligned with the new ISMRM guidelines. It's really high resolution and really focused, really weighted towards the SWI side of things so that we can understand microbleeds. The next sequence is a motion-corrected T1 weighted volume to look at the impact of motion on identifying neurodegeneration signatures. The third sequence is actually two. It's a long-labeled, post-label delay ASL, and then a multi-post-label delay ASL that John Detra has put in place for us. And then you can choose to do any of these advanced sequences if you want, or none at all. It's your choice. And we want to think of this as a platform where we can propose new sequences that we want to run together and come to answers quickly on what these new sequences would do. So to think of it another way, just more visually, scan T1 weighted volume and flare is the foundation. There's these optional neurodegeneration focused sequences that we're offering. You can do those or skip those, and that would, if you want to do your own optional sequences during that remaining time, that's your prerogative. You could do the other scan sequences, or you could do your own local sequences. It's just want to stress that there's some options there for you. Let me switch to FDG. This is a couple of slides provided by Dave Jones from Mayo Clinic ADRC, and the citation is there to the machinery for an image classifier for FDG. FDG is useful for helping to understand the etiology of what's happening, whether it's neuro-related or non-neuro-related, whether it's a degenerative process or non-degenerative process, and then among the degenerative diseases, whether that might be an AD-related process, Lewy body, or FTD-related process. And Dave Jones has this classification tool that will handle these FDGs. And just to show you what it looks like, here's an FDG exam. It's submitted to the classifier, and a neighborhood graph is constructed, and then you get a probability of what the underlying etiology might be. In this case, it was posterior cortical atrophy, or PCA. There was an 88% likelihood of being PCA and a 0% chance of being cognitively unimpaired. And indeed, that matched on to the neuropathology and the clinical syndrome that was present in this case. Another case with ostensibly a similar FDG background that was submitted to the classifier, and this one looked more dementia with Lewy bodies according to the network graph. 81% likelihood that this was dementia with Lewy bodies, 0% likelihood that it was a cognitively unimpaired person. So this is the kind, and that matched on to the pathology at autopsy and also the clinical syndrome that was observed. This is going to, he's doing a study with how this may enhance the radiological reads, and that looks like it's going to do very well. The overall point of this, though, is that the FDG classifier here is going to help us identify neurodegeneration signatures of all the major, at least, neurobehavioral, clinical phenotypes that we see, as well as neuropathology that we see. So it's useful in people with symptoms, and we want to encourage you to think about that for clarity. The analyses will be led by Dave Jones and his team at Mayo, and it's based on NeuroPath Ground Truth, this classifying engine. And he'll be able to supply those results back to you for you to use in the care of your patients if you so choose. Let me switch topics to blood collection. We've already heard about the ADCFB protocol. This has been happening in 25 of the 37 ADRCs already. There's longitudinal data there, longitudinal samples there already. Much of it that could be perhaps cross-referenced with the scan data that Bill Jagas just showed us. We are hoping that there'll be continuity with the ADCFB. That's what we're adopting for clarity. And we're simply asking sites to continue to collect that protocol and send those those samples to NECRAD. There'll be many things planned with this, and we'll work closely with the Biofluid Steering Committee on this. But things like p-tau217, A-beta42, GFAP-NFL would be the sort of the planned menu. TDP-43, as we'll hear in this meeting, and alpha-synuclein, those are becoming more likely that there'll be something available for as a blood test in the near future. And also, we're thinking very closely and watching the data on dried blood spots as a very convenient, very simple way of getting the core biomarkers of things like p-tau217. Okay, just one more slide, and that's just something we're observing as we've been doing these surveys with you. And by the way, we'll hear more of our survey results, not just for our main survey that we did, but also the inclusion survey and the disclosure surveys that you were so kind to fill out. With the survey around PET choice, we see a number of sites wanting to use fortaucipir and flabetapir. This is great. They're great tracers. Lily gave us a number of free doses, and based on what you've said you want to do, those doses would likely be used up after the first year of the project. And when we initially modeled this, we factored that in, that some doses would be free and some doses would be at their full price rate. But if we adopt, or if we use all the doses that you say you want to use, we may run ourselves into a little bit of a dependency. And I just want you to start thinking about whether there may be another tracer that you want to use besides FTP and flabetapir because of this high demand issue. Just want you to be aware of that. Okay, these are just some updates that we had for you. We'll be giving more updates in the breakout session over lunch. This was, it was only restricted because of the size of the room. You're welcome to listen online if we don't get you into the actual session. You're very welcome to join us for that. Also, our next webinar is in June, and there's some contact information for our team members if you have questions on any of this. All right, I'll stop there.
So we don't have time for questions now, but this isn't the only time that you'll see the Clarity team. So save your burning questions, either for later Clarity sessions or for tonight or for a break. Okay, so transitioning now to our panel discussion, I'd like to welcome to the stage Shannon Rissaker from Indiana University, who's going to talk with us about leveraging clinical and research imaging data in the new era of AD treatments and increased engagement of diverse populations. So when we were thinking about putting together this session, we wanted to provide ample time for engagement from you and the audience, as well as give time for many of our experts to come and share their perspectives on new and innovative things that they've been working on. And so we opted for a single presentation and a longer panel discussion to hopefully spur some of that discussion. So now is the time to get those questions ready.
Thank you, Emily. I can't see the slides either, because I guess I'm short enough to not be able to. I want to thank everybody for being here, and I have no disclosures, but I really want to highlight the assistance of the other neuroimaging core steering committee members who helped plan this session, as well as our excellent panelists who you will all see here in a few minutes. So quickly, I want to go over the outline of what I'm going to talk about. So first, I'm going to introduce some of the results from the trials for the approved and under review anti-amyloid monoclonal antibody treatments. I'm going to talk briefly about amyloid-related imaging abnormalities, or ARIA, which is a major side effect of these treatments. I'll briefly touch on the ethno-racial diversity of the clinical trial samples, and then sort of shift gears to ask about some sort of future questions for which the neuroimaging cores and really the ADRC network could be involved in studying additional types of questions that come out from these antibody treatments. And lastly, I'll introduce the panel and put forth a few questions that we thought of, but we also value your input, and please ask questions. So initially, I'll talk about aducanumab. They initially ran 2 simultaneous phase 3 randomized controlled trials, ENGAGE and EMERGE. In all of these, they included amyloid PET positive MCI and mild AD. There were multiple MRI scans to screen for ARIA, and the drug receives accelerated approval by the FDA in June of 2021. However, Biogen announced early in 2024 that they would no longer be supporting aducanumab. Here are the sort of top-level trial results. EMERGE, one of the 2 trials, did show significant results, with their primary endpoint being CDR sum of boxes, and a 22% slowing on CDR sum of boxes with aducanumab treatment. However, the ENGAGE trial did not show significant results in any of the clinical outcomes. When looking at the amyloid PET, there was significant clearance in both the EMERGE and the ENGAGE trials. Amyloid was reduced by about 70% in one and about 60% in the other. In addition, approximately 48% of the patients in EMERGE reached what we're terming full track or treatment-related amyloid clearance, or in other words, by the end of the trial, they fell below the cutoffs for PET positivity and thus had an amyloid PET negative read. ENGAGE, it was slightly less number of participants, it was about 30%. I want to highlight some of the other imaging outcomes in each of these trials, given that this is an imaging session. So it was a really small number of individuals also underwent tau PET in the aducanumab trials, and did show some reduction in medial temporal tau PET signal, although, like, I'll really point out the sample size are very small. And then they also looked at atrophy using structural MRI scans, and showed that the lateral ventricle showed more expansion in patients who received aducanumab treatment relative to placebo. And this is something that will come up again and again, but it suggests perhaps some accelerated atrophy. The next one is donanemab. There was initially a phase 2 study which showed clearance of amyloid and less decline on a clinical and cognitive measure. Thus, they initiated a phase 3 study named what was Trailblazer ALS 2. It had about 1,700 participants split equally between the groups. Again, they're enrolling only amyloid positive on PET in their case, the MCI due to Alzheimer's disease or mild dementia due to Alzheimer's disease. And I want to note the centiloid cutoff here was greater than or equal to 37, which is a bit high, so I would think that perhaps that's because they wanted people who have a decent, large amount of amyloid deposition. In this study, the participants also underwent tau PET with rotosapir and were subcategorized into a low and medium tau group and a high tau group, and the analyses were generally done either in the low to medium tau group or in the full sample. The primary endpoint was the ADRC for the donanemab trial, and they did show in the low to medium tau population a 35% slowing in progression of the ADRC, while in the combined sample, there was about a 22% slowing of change in the ADRC. The amyloid PET data from the donanemab trial showed pretty substantial clearance of amyloid. with almost 90 centiloids between the baseline and end of the trial. And again, the number of people who met full track, or in this case, fell below 24.1 centiloids on amyloid PET at the end of the trial was about 80% for the low and medium tau group, and a little under that, but close to 80% for the combined group. Similar to the aducanumab trial, there was an appearance of accelerated atrophy in the patients who were taking donanemab, with larger ventricular expansion in both the low and medium tau population and the combined population. So lastly, I'll talk about lecanemab, or Leqembi. There was a phase 2 trial that demonstrated amyloid clearance and positive changes on fluid biomarkers in clinical and cognitive outcomes. It also had multiple doses being tested, and so they determined from the phase 2 trial that the 10 milligram per kilogram biweekly was the most effective. One interesting thing about this trial, it also had an open label extension, which occurred somewhere on an average of about 2 years after the study. So during that period, the group that was treated with lecanemab during the trial went off of the medication for about 2 years until the open label extension. And during that gap period, they showed clinical progression similar to the placebo group who had never been treated with lecanemab. Some amyloid reaccumulation and AD-like changes on plasma biomarkers. So this then progressed to a phase 3 trial, or Clarity. It had about 1,800 participants split between the placebo and lecanemab groups. Their primary endpoint was the CDR sum of boxes, and they showed about a 27% slowing in change on CDR sum of boxes over the course of 18 months in patients that were taking lecanemab. If you look at the amyloid PET, you also see pretty substantial clearance of amyloid of about 60 or so centiloids. And in thinking about the number of participants who became amyloid PET negative or had full track, that would be about 80% by the 18-month visit. This is from the phase 2, so that's why there are so many different lines on there. They were testing different doses, but if you just pay attention to the green line, which is the one at the top, and the black line, which is the placebo group, the 10 milligram per kilogram biweekly dose did seem to show an effect on ventricular volume, such that those who were taking lecanemab showed faster expansion of the ventricles and perhaps more brain atrophy relative to the placebo group. So lecanemab received full approval in June of last year. The appropriate use recommendations were published also last year. They suggested that the people who would be eligible to receive lecanemab would be amyloid positive either via PET or CSF, and must have either MCI due to Alzheimer's disease or mild dementia due to Alzheimer's disease. There were a number of exclusions for why people may not be able to receive lecanemab. Some notable ones were the use of anticoagulant medications, having a stroke, TIA, or bleeding disorder in the last 12 months, having any history of seizure, and having CAA-related inflammation or amyloid beta-related angiitis, or ABRA. In addition, on MRI, they suggest the use of a safety MRI for the purpose of eligibility to look at cerebrovascular damage. Some of the criteria for exclusion are listed here, namely that you can't have more than 4 microhemorrhages or a macrohemorrhage, which is defined as 1 centimeter at largest diameter, superficial siderosis, vasogenic edema, more than 2 lacunar infarcts or stroke in a major vascular territory, or have severe subcortical hyperintensities. These are all exclusionary for the use of lecanemab. The appropriate use recommendations also suggested doing ApoE genotyping, as those who carry an ApoE4 allele are more likely to get ARIA. This is suggested really for counseling of patients. There's no formal restrictions on ApoE4 based on ApoE4 genotype, but just to advise patients about what the possible risks are. So the suggested imaging protocol for the lecanemab treatment is an amyloid PET, or as I mentioned, CSF, for eligibility to determine whether somebody is amyloid positive, as well as an eligibility and safety MRI that occurs within 12 months of the initiation of treatment. Then once treatment has begun, there are multiple safety MRIs to look for the presence of ARIA, specifically before the 5th infusion, the 7th infusion, and the 14th infusion. In addition, in the appropriate use recommendations, they suggested that patients maybe should undergo possible safety MRIs before the 26th infusion as well, specifically for those who have ARIA during the treatment course that resolves, or potentially ApoE4 carriers, although that is not a required part of the prescribing information. So in the clinical imaging protocol for amyloid PET, generally they promote using one of the FDA-approved tracers, although we'll talk a little bit later about what to do with non-FDA-approved tracers. The MRI minimum sequence for eligibility and safety it includes a T1 weighted scan, a T2 flare, a T2 star GRE, or a similar scan like a susceptibility weighted imaging SWI scan. Notably, SWIs are a bit more sensitive to microhemorrhages, so it may be important to be consistent with those scans across the treatment. And in addition, a diffusion weighted imaging scan. So as I mentioned earlier, amyloid-related imaging abnormalities, or ARIA, are one of the most common side effects with monoclonal antibody treatment. They're divided into two types: ARIA-E, which is characterized by parenchymal edema and sulcal effusion. This is little bit more common than ARIA-H, which is the other type of ARIA, which is characterized by parenchymal microhemorrhages and/or superficial siderosis. The results from the different trials with regards to ARIA rates show that they vary quite substantially based on which drug you're talking about for both ARIA-E and ARIA-H. But the vast majority of these are asymptomatic, with the symptomatic ARIAs being relatively low for both donanemab and lecanemab in the single digits of %, while it's somewhat higher in aducanumab. And as I mentioned, E4 carriers are more likely to develop ARIA, with about double the rates in E4 carriers relative to non-carriers, with particularly high frequency in ApoE44 homozygotes. So I'll briefly just introduce the ethno-racial diversity of these clinical trials. On the whole, the patients included were white, with almost 80% of participants in the entire, if you sum up all the trials, being of white descent. The next most common racial group was Asians, at about 10% of the total number of patients included in these trials. Two other ethno-racial groups that are of particular frequency in the United States, especially, are those racialized as African American or Black, and Hispanics. As you can see, the numbers were pretty low for the inclusion of these types of participants in the clinical trials, with only about 1.6% of the overall patients in trials being from African American or Black racial groups, as well as about 5.7% coming from Hispanics. There were very few representations of other racial groups in any of the trials beyond the ones I've mentioned. One reason may be because, as mentioned actually earlier in the biomarker session, as people who are not non-Hispanic whites tend to have lower biomarker representation and tend to be less likely to be positive on the screening tools for clinical trials. This is data from a very recently published paper that came from the AHEAD 345 trial, which is in cognitively normals, but I think may also be true for the patient trials that have occurred. And it showed that individuals who were Hispanic Black, Hispanic White, non-Hispanic Asian, and non-Hispanic Black had significantly less percentage of being positive on a plasma screening assay of A-beta 42/40 ratio relative to non-Hispanic whites, suggesting that perhaps those biomarkers are not as effective in those groups, or that they just don't show as much amyloid positivity. So now I'll transition into sort of future directions. One centralized resource for the outcomes from monoclonal antibody treatments, as well as a resource also for patients looking to become involved in either clinical trials or treatment, is ALSNet. A lot of information about the outcomes from monoclonal antibody treatments will be contributed to ALSNet, and it will be a centralized resource for the exploration of different research projects related to monoclonal antibody treatments. So as neuroimaging cores or biomarker cores are really just generally being part of the ADRC network, there are probably a number of different ways, and I only listed a few, that the ADRC network could contribute to a better understanding of the outcomes of the monoclonal antibody treatments. They could work with the ALSNet data or independently. One would be prediction of ARIA risk using either novel neuroimaging sequences or perhaps different PET tracer targets. We, as a network, could also look at the impact of treatment on other neuroimaging biomarkers. So, for example, functional brain scans or other PET targets. And then most of the clinical trials were approximately 18 months, which is, in the course of Alzheimer's disease, a relatively short period of time. So the ADRC network and our regular sort of annual intervals of follow-up may be a good opportunity to have longer-term follow-up with these individuals, where they could receive amyloid or tau PET as needed or if wanted, as well as additional MRI techniques. But this, like I said, is just a few ideas. There's many, many more research questions. So with that, I'd like to invite up our panelists. I'll give them a second to come up. All right, so the last one up, but is Adam Brickman. He's a professor of neuropsychology at the Taub Institute for Research on Alzheimer's Disease and the Aging Brain and the Gertrude H. Cervesky Center at Columbia University. I tried. The next one is Gil Rabinovich. He's the Edward Fine and Pearl Landreth Distinguished Professor at in Memory and Aging at the UCSF Department of Neurology. And last but not least, Dugu Tosin, who's a professor of radiology and biomedical imaging at UCSF and the founding director of medical imaging informatics and AI at the San Francisco Veteran Affairs Medical Center. So I and the rest of the Neuroimaging Core Steering Committee put together some potential questions or topics for discussion, but we welcome feedback from the audience. For example, the first one is, how can neuroimaging cores best integrate with clinical treatment for monoclonal antibodies? For example, how do we use ADRC scans potentially for treatment eligibility, even when perhaps some of the scans are not FDA-approved tracers, like in the instance of PIB? How can we reduce the need for repeat scans for both research and clinical purposes, as well as clearly educating individuals as to why they may need to have repeat scans, as this might be somewhat confusing? And is the pretreatment baseline imaging or a pretreatment visit needed for enrollment in ADRCs, or should post-treatment participants also be included? The next sort of topic that we proposed is, how can neuroimaging cores contribute to answering additional research questions about monoclonal antibody treatments? For example, how could we standardize clinical scans for research use? As I mentioned previously, do longer-term follow-up, or look at changes in other neuroimaging measures? As well as, could we explore novel neuroimaging measures both for ARIA prediction and potentially to help with eligibility screening? And then lastly, how can neuroimaging cores and neuroimaging research help to promote diversity and equity in monoclonal antibody treatments? For example, can we use new technologies in the areas of neuroimaging to expand the reach of screening tools for anti-amyloid monoclonal antibody treatment to underserved communities? For example, something like a portable MRI. And can we develop culturally appropriate dialogue with diverse communities about the imaging and biomarkers, as well as other things that go along with treatment with anti-amyloid monoclonal antibody treatments? So with that, I'll turn it over to the panel. And please, as an audience, please ask questions as you have them. Thank you. I don't know who wants to start out. Adam.
I guess I'm seated
first.
or I'm listed first. So thanks so much for inviting me to be a part of this panel. I don't remember all of the questions, but I will say that, you know, at Columbia, one thing that we're trying to do is to get formal clinical reads on all of our amyloid PET scans as people enroll into our center. That involves a lot of collaboration with our Department of Radiology. It involves, you know, having clinical scans that were acquired for research purposes as part of the medical record, and so there has to be a lot of discussion about that with our participants. So one thing that we do is, or we're planning to do, at least in our center, is as people get FDA-approved amyloid PET scans, they're read by the radiology department. They consent to have those as part of the record, and then we have a formal clinical read that we can share and use to refer to clinical trials if that's in the interest of the participant. So I'll start off with that. I have lots of other stuff to say too.
Yeah, thanks for inviting me to be on this panel. I think it's a very timely panel. And I think actually the ADRCs are in really great shape to help with the implementation and addressing research questions related to these new classes of therapies. You know, thanks to the vision of leadership, we have SCAN, so just being very neuroimaging focused, and Clarity now starting, which is going to enable much more widespread molecular imaging and MRI throughout the ADRCs. And I think this is going to be just a terrific resource to try to address some of the unanswered questions regarding the long-term efficacy and safety of these therapies. And, you know, we're talking about neuroimaging, but we're in the same position with biomarkers, with, you know, major standardized biomarker initiatives across the centers that will help us look at fluid biomarker changes. I think we're at a time where it's going to be imperative to disclose research results to our participants, especially those who may be eligible for these therapies. I think that's a new thing for a lot of the centers. But now that we do potentially have not just prognostic information, but actual treatment options for people who are positive on these you know, biomarkers, we really need to think about disclosing results to people. And I think this is actually an exciting time of transition. So the ADRC program for decades has been longitudinal observational. And I think in the next 5 to 10 years, as this class, but hopefully new classes of therapies come online, I think the center program may shift to being much more about doing research with different interventions. And this is just a new opportunity for the centers, and I think we'll have to sort of think about what we're doing and how to adjust to this new era. But, you know, all of this is very timely. So those are just some kind of bigger picture thoughts, and happy to address the specifics down the road. But let's turn it over to Dugu.
Yeah. Thanks for the invitation, being in this panel discussion. So I'm just going to follow the research question point of view from the Guild. So when we look at these treatments, the results from clinical trials, there's a huge heterogeneity. And around that, like how each individual is responding to these treatments. And there's lots of unknowns from research perspective we need to know, and also from inclusion or a referral of the patients to these different treatments. So the Clarity is actually a wonderful example in that direction, allowing us to better profile our participants, our patients, using different biomarkers, imaging biomarkers, because we know that depending on their pathological composition, their neurodegenerative composition, different things are contributing to their cognitive decline, clinical decline. So it's really important to understand what are the drivers of their clinical symptoms and cognitive decline, to better understand if there are good candidates for these available treatments. So this is like one area ADRCs will be super, I believe, going to be super involved in those research questions. Can we use different imaging modalities to better understand? And also from the risk factors perspective, as Shannon very nicely summarized, diversity is a big question that hasn't been answered by many of these treatments. And we know that diversity, as Shannon was showing some of these data, there's also pathological profile differences at different different populations. You can refer that to their genetic makeup. You can refer that to their social economical status. But we also know that there is comorbid chronic condition differences. And the inclusion criteria doesn't include those at this point. And many of those could also impact their response to treatment, but also their risk for ARIA as well. Like cerebrovascular risk factors is one of the items, but we still don't know the actual mechanism. And we do have very state-of-the-art imaging techniques to look at some of these aspects of the brain function and how it is clearing the pathology and how it is responding during the treatment, how those mechanisms are tapped into, and what are their involvement in terms of their risk to develop ARIA and the symptoms. So that is definitely another area. ADRCs are very well positioned to implement and test, validate some of these new imaging techniques to profile diverse populations and their potential risk or response to some of these treatments. I'm going to stop there. I think we can definitely talk for hours about these. But
I did want to make one very specific comment that came to my mind as Bill and Sterling were presenting on scan and clarity. I think we're, from the PET side, I think we're in really good shape with standardized PET protocols. From the MR side, I think we're in pretty good shape, but I did notice that, hemosiderin sequences, so if it's gradient echo or SWI or QSM, are optional in scan and clarity. And I'm wondering if we want to rethink that moving forward, because obviously identifying CAA before treatment and following hemorrhagic projects with treatment is something that's going to be very important for this class of drugs, the anti-amyloid antibodies. So I'm wondering if we want to actually think about expanding sort of the required MR sequences to include some form of hemosiderin. Not every site is going to be positioned to be able to do QSM, for example, but maybe we can find sort of a lower common denominator that would be added as a required sequence to scan and clarity. Just an idea, and I don't want to put additional work on everyone's plate with scan and clarity, but it does seem like an important gap right now in our imaging data set.
So I'll circle back to some specific questions that were underneath here, and then please, again, anybody who has questions, please come ask them. With regards to your ADRCs, Adam touched on this a little bit, but so how are you using ADRC collected data for assisting with people who do want to join antibody treatments? Are you using the PET data that's being collected as part of the centers? And what are you doing in the cases where it's not an FDA-approved tracer?
In our center, we are using FDA-approved tracers, so that's not really an issue. But we certainly, this is more part of our renewal, which we're writing right now, is certainly to use those PET data to disclose results among people who are interested in knowing their positivity status and integrating very well with our clinical trials unit so that there's much more crosstalk than there has been historically. If it's okay, I want to step back a little bit and hit on the diversity issue, because this has come up a lot. I think that we all recognize the importance of diversity, but a word that we don't hear as often is representation. We can have diversity without representation, and I worry that the field is sometimes using clinical trial data, which has all sorts of ascertainment bias in it, to make epidemiological conclusions about the biology of Alzheimer's disease across race and ethnicity. So in the AHEAD trial that we just saw, for example, there was some diversity and there was some observed biomarker differences across race and ethnicity groups. But we can't really attribute those to biological differences. The different groups have different representation. We saw, for example, that in the AHEAD trial, I think the average education for Black participants was 16 plus years. In our data, it's 11 years. So the difference in the population education and the education of the people enrolled in the trial varied by education, by ethnicity and race, suggesting that there's some real bias in there. So I want to, as we start to really emphasize the importance of having inclusivity, diversity, we should equally emphasize the representation of our diversity so that we're enrolling people who actually represent the communities that they're from.
Yeah, I could actually make a comment about that regarding things we've learned from the ideas and new ideas studies. So these are clinic-based studies, so they're more real world than the ADRCs, but they're still specialty clinics, so take that with a grain of salt. But in ideas, and now replicated in new ideas, and we'll present this at AIC, we do see differences in these memory clinic populations in the rates of amyloid positivity, with non-Hispanic whites having the highest rates and seeing lower rates in Latino, Black, and Asian American patients in the memory clinics. That said, the gaps aren't that huge. There are a few percentage points. They're significant in large numbers statistically, but they don't explain the underrepresentation in clinical trials. I don't think they're explaining very much of that. Regarding Shannon's specific question, I think this is going to differ center by center in terms of how you use the research scans. So I encourage every center to really think about, how to be efficient and minimize repetitive imaging for your participants, but the regulatory situation is probably going to differ a little bit. So at UCSF, we have been doing amyloid PET reads actually for many years, and we use those amyloid PET reads as qualification for treatment, including people imaged with C11PIB. We don't have our radiologist or nuclear medicine team re-review the scans formally, but we do have a multidisciplinary committee that reviews all the lecanemab referrals, and that includes a neuroradiologist and it includes a nuclear medicine specialist. So they do look at the scans and make sure they agree with the read that was done in research. For MRI, we have, again, this is idiosyncratic, but we have a research-dedicated MRI scanner. And what's critical for ARIA is that you image patients before and throughout treatment on the same scanner if you can. And that's going to be a different scanner for our clinical scans. And so unfortunately, while we can review the ADRC MRI and make sure they don't have exclusionary factors, they're going to need at our center to be re-imaged at least for the FLAIR, T1, and SWI as a baseline, because then when they're getting their ARIA monitoring scans, they're going to be imaged on that clinical scanner. But I expect this is going to vary center by center.
Yeah.
Sorry, you couldn't see us, so I thought I would interrupt. So in our hospital system, the decision was made that because of these repeat MRIs and access to scanners, it's going to be a 1.5T MRI. And because, we're imagers, so we're not loving that, but I think that I'd be interested in kind of a discussion of what the implications for that with the repeat imaging necessity, plus thinking about things like QSM and these other sequences that we're only going to get at 3T, that you're suggesting we should think about those being mandatory because they provide such valuable data.
I think, that's a real issue. I worry most about microbleeds at baseline and the sensitivity of detecting microbleeds. I worry about that anyway once, we're all hyper anal about looking for little holes on these scans, but I think in the real world, you know, the microbleed criterion of having 4 exclusionary hemorrhagic lesions might be problematic at 1.5 Tesla. I think the ADRCs are in a great position, particularly if we register, if we enroll people who are on treatment, to start developing new predictive algorithms to understand, not just based on baseline microbleeds, but maybe combined with other sources of biomarker data, including the vascular biomarker that apparently the centers aren't collecting according to that survey we heard about. But those could be very, very helpful in combining with imaging data to come up with new ways of predicting who's at particular risk for developing ARIA when suboptimal MRI scanning alone won't do.
Just want to quickly add something to Adam's response. It's one of the things that puts ADRC in a really nice spot is the diversity, like the heterogeneity across the site. So if we think about the real life application of these treatments, we're not going to be able to impose standardized imaging techniques or really high quality imaging techniques. So it will be really important, as Adam mentioned, thinking from imaging perspective, from analytics perspective. It's good to standardize the images, but at the same time, can we identify certain biomarkers that are agnostic to the imaging modality or imaging approach we are using? Because that's the only way we can make these accessible and scalable in real life and available for everyone, regardless of if they're seen in a memory and aging center or regular clinical setting.
Yeah, I may be wrong about this, but I think the trials did allow 1.5 and 3T at the sites, so that part is covered. I share Adam's concern about sensitivity for ARIA-H, but also for ARIA-E. I mean, we know that 1.5T may not be as sensitive, and so you know, it's a trade-off between accessibility versus, you know, the quality of the scanner, and that's a decision every site is going to have to make.
So I'm going to echo first what Gil said. I think I agree that it'd be a great idea and clarity to put a hemosiderin sequence, and we're going to implement that at USC. But I was surprised on another issue. I was surprised to see with the appropriate use recommendations, they don't come strongly out to say that people should be ApoE genotype. Considering the robust differences in the side effects and questions, in my opinion, regarding looking at the data and whether the efficacy in ApoE4 homozygotes, that doesn't seem right to me. I'd be curious what other centers are doing.
So actually, the original aducanumab appropriate use recommendations were a little ambiguous about it, but they came out quickly with a correction that recommends ApoE genotyping for everyone who is being tested, who is being considered for the treatment, and the lecanemab AUR recommend ApoE genotyping for everyone. So it is a strong recommendation, actually, and there's some pushback around that. Patients sometimes don't want to know this information because of the impact on their family and so on, but the AUR actually come out strongly in favor of ApoE genotyping.
So I'd be curious to know the people who are administering lecanemab, how many are giving it to ApoE4 homozygotes and how many aren't? That's just a sort of a polling question. We have one is.
So everyone who is, we are.
Okay.
Yeah. With appropriate counseling.
Okay. So I think also on that topic and the point of diversity is, though we know that ApoE4 has a differential risk in different ethnic groups, what we don't know is we don't have enough people in the trials to show whether the effects on side effects are similar in different groups. So again, echoing the need for diverse populations.
And so this is another reason why ADRCs should enroll in ALSNet and become ALSNet sites. The Medicare registry for lecanemab does not actually collect data about ApoE genotype, remarkably, which is crazy. ALSNet, of course, does collect that data and a lot of other data. And so if we're going to answer these questions about ApoE risk in more generalizable representative populations, you know, the Medicare registry is not going to answer that.
Hi. Yeah. Juan Carlos Lopez Alvarenga from Population Health Biostatistics in UTRGV. Thank you for this discussion. I'm clinical epidemiologist, so I was trying to understand, for example, you have the number needed to treat a grasp from the slide that is about 3. With 3 people, you have a very good response from 1. But number needed to harm is about 6. So it's very close to each other. So I was wondering, the area that you are having in the imagine, how they are related with the clinical expression, and if it's in that number, so that means that there is not so much difference between the harm with the benefit. So it's something I ask to you.
I think that's sort of a philosophical question. I think I'm always surprised by our term asymptomatic ARIA. We measure all sorts of stuff in the brain, like amyloid, that is sometimes without obvious symptomatology, and we assign all sorts of valence to that. And I think that we can use some of these outcomes as indicators of very poor outcomes that might have prognostic indication. So I agree that the risk-benefit trade-off is a little bit questionable in some of these trial data, but I didn't think that's what this was about, this panel, so I'm not going to go there.
But I feel compelled to offer a counterpoint to that. So we actually did calculate these numbers. And so if you look at any event of ARIA E or H, that's going to give you one number needed to harm. But if you look at ARIA E or H that causes symptoms or causes severe effects, because remember, our patients have an incurable progressive neurodegenerative disease, and they may be willing to take risks. So let's talk about severe or symptomatic ARIA. The number needed to harm was in the high 30s for lecanemab and donanemab, and the number needed to treat, for example, to prevent one conversion from MCI to dementia was around 9 to 12, depending on which specific group you were looking at. And so, that's another way to look at risk-benefit, maybe.
Sorry, but it's different data, right? Because you didn't show that.
That's not in the trial data.
Yeah, no, these are calculations that we made at our center.
I think ultimately it has to be an informed decision by the patient. Thinking about people that I know saying that you might experience brain bleeding or inflammation, but it probably won't be symptomatic. Seems like a decision that needs to be made by the patient. Yeah.
Yeah, Dave Morgan, Michigan State. You highlighted very appropriately in your introduction the fact that we do see some other potentially adverse events, which is things like ventricular enlargement. This goes all the way back to the phase 2 bapineuzumab trial, that we've seen these things. And we've also seen hippocampal atrophy. And I guess, a priori, I've always thought more brain is better. So I'd like to hear the panel or other people explain how could this be something that is indicative of benefit in terms of...
I gather you're not on Twitter. This is like all I see on Twitter. It's like, I don't know.
I can try.
It's asymptomatic atrophy, by the way.
Their cognition improves.
Right.
It goes back to those research questions, unanswered questions we can address with the ADRC data, but you are removing something from the brain, right? With the amyloid treatments, there is amyloid removal, and like one explanation could easily be that it's just microglial activation, and all that is removed. So it's kind of a pseudo atrophy, not real neurodegeneration, but that's clean clearance reflected. But again, it's one of those unanswered questions. That is not modeled properly, and clinical trials haven't touched that in full detail, so something we can look in that. And also the regional effect, the regional clearance of the amyloid, that is also something we haven't truly discuss. It's not everyone that is showing amyloid clearance also showing the clinical benefits. It's important to understand where the amyloid is cleared and what are the downstream effects, like looking at some of the functional imaging measures, because those are more directly related to their symptoms and cognitive performance. And those are not included in the clinical trials, but ADRCs do have that opportunity to look at fMRIs or ASL data to better understand that functional changes happening in the brain and how those are translated to their response to the treatment eventually in short term as well as long term.
Yeah, I'm not on Twitter, thankfully for my mental health. But Nick Fox has thought a lot about this, and I don't think we know the answers, but some of the points that he has made are, one, the changes in volumes don't correlate with any clinical outcomes, better or worse. Two, there's more subtlety, actually. So in some of the trials, there's actually a small benefit in terms of progressive hippocampal volume loss, but a harm in terms of overall brain volume or ventricular volume. So there's more subtlety to the data than the brain is shrinking. And third, there are many treatments in neurology and in other fields of medicine that cause changes in brain volume. So just to give a couple of examples, there are MS drugs that clearly improve outcomes and yet also cause reduction in brain volumes. They're called pseudoatrophy in the MS field. Dialysis reduces brain volume by, I think, 2 or 3% after a treatment, yet no one is going to argue that it's not good to give people dialysis. And the effects are very, very small in terms of the volume. So those have been some of the points that Nick has brought up, but I don't pretend that I know the answer to this. I think we should be vigilant, and it's a great opportunity for the ADRCs to contribute longer-term outcome data.
Yeah, that was the point I was about to say is, I think this is a question that longer-term outcome data potentially through the ADRCs would be really helpful to understand whether this accelerates over time, it goes way over time, and we just don't know because the trials are primarily, about 18 months. So.
Yeah, and one other comment on that topic, but I have a separate question, is that that supposedly the amount of amyloid removed from the brain isn't sufficient to account for the change in volume, and the fact that we don't see any changes over 18 months, it hasn't been looked at that carefully, and it's not clear whether the changes, cognitive changes or others, might be manifest 5 years out. We just don't know. Victor Henderson from Stanford. So we've heard a little bit about subgroups that might benefit differently from treatments such as ApoE homozygotes, but we really haven't talked about sex, and there seemed to be a real effect modification by sex in the lecanemab trial, such that women may not, whatever the small benefit is, this small benefit may not be achieved by women, and I wonder whether there are other comments or thoughts about that.
I do. So, in the lecanemab trial, they didn't incorporate tau PET in everyone, and they didn't stratify people by tau PET. But actually, there are a lot of data sets that suggest that females, for any given level of impairment, have a higher tau burden than males. We also know that people from the donanemab phase 3 and phase 2, that the more tau in the brain, the smaller the clinical benefit of amyloid removal. And so my guess is that at least some of the differences in treatment effects that seem to be related to biological sex may actually be attributable to different tau burden at baseline. And in fact, in the donanemab trial, there is less of an effect in sex when you stratify low, medium versus high tau. There's less differences between males and females, suggesting that explains at least part of that. And I actually think it may explain some of the differences in ApoE4 homozygotes as well, but we'll have to see.
Yeah, and I think that's a really good point. And I did notice that in the donanemab trial, there really wasn't much of a sex effect. On the other hand, in aducanumab, there was sort of a trend in the same direction. And,
Again, no tau PET stratification.
Fair enough. Thank you.
Hi, my name is David Lowenstein, One Florida ADRC. Hi, Gail. Hi, everybody. We deal a lot with diverse ethnic, ethno-racial, and cultural groups. And so one of the things that struck me, we're talking about the CDR sum of boxes. we didn't speak very much beyond the CDR sum of boxes. We've really been talking about the neuroimaging, but you have to relate the neuroimaging to decline over time. So there's increasing evidence that the CDR sum of boxes vis-a-vis the informants, the relationship of the informants, whether you weight the cognitive part of the test or you more heavily weight the informant part of the test, can be exceptionally biased with regards to, for example, Spanish-speaking groups are not monolithic. There are many differences in Hispanic Latino groups. Same thing with Southern and Northern raised African Americans. So my question to the group is, given representativeness that Adam brought up so eloquently, given the fact that we're dealing with CDR sum of boxes, which may not be included in these clinical trials, as Gil had talked about, or some other people had talked about, are we, and the effect sizes of the CDR sum of boxes that nobody commented on, when we look at representativeness and we look at cognitive measures and we look at decline and we try to relate it to biological outcome, are there things we may be missing when it comes to unrepresented groups?
Yeah, I mean, I think those are great points in terms of the cognitive outcomes. There's certainly a lot of work being done on harmonization and looking at invariance across different groups. And certainly our field and the ADRCs are part of that work. And I think better outcome measures or better versions of the current outcome measures that we have can be derived that are more appropriate or invariant across different cultural groups. Psychometric, advanced psychometric harmonization. I think CDR is a great instrument, but for all those reasons, it might not be a great instrument for all people.
Okay, I want to jump in. We got one more question. That'll be, unfortunately, it for the panel.
Great, thanks so much. It's a really exciting time for the field, and that was a great panel. I'm excited for the imaging course to be able to look at this data in real life. We've been reading about the clinical trial data, but we can generate our own now. But we're also all very excited about the blood biomarkers. And with incredible promises for access and inclusions, I was wondering what was your opinion about the future of neuroimaging versus blood biomarkers, both in the context of ADRCs, but also out there in the real world, especially in the context of treatment.
It's all great. I think I've embraced personally both blood biomarkers while still celebrating, the imaging biomarkers. And I think with respect to looking at efficacy and safety outcomes, certainly combining data from both sources is going to be really, really important, I think. I'll leave it at that.
Renaud, I'm closing our imaging core at UCSF, and I'm selling our PET scanner, so.
Am I being fired right in front of everyone?
Look, imaging is going to be really important. The blood biomarkers that we have now are very good at telling us if there's pathology in the brain. They tell us a little bit about response to therapy. They don't tell us how much pathology, at least the markers that we have now. They don't tell us where it is. They don't tell us about changes in volumetrics that are going to be very important to study. And so I think that certainly in the ADRC setting, we should be striving to do both and to actually understand, what each modality is telling us. They're measuring different things and they're telling us different things about how we're modifying the biology of the disease. Now, in clinical care settings, of course, it's a different story, and then you're thinking about cost and access to these advanced technology. We heard about the outrageously high cost of flirtaucipir. Sorry if anyone's here from Lilly, but it's really unconscionable. And so, because it's the only FDA-approved tracer that's out there. So, there we have a lot of other parameters, but in the research setting, of course, we should be looking at all of these things. So, Renaud, I'm not going to actually, I was joking, yeah.
All right, well, with that, I want to thank the panel so much for all their insightful conversation about this topic, and I'm sure it will continue.